My name's Nikki Evans, and I'm one of the faculty of this course. So the idea of this course is that we give you a little bit more teaching rather than just the intensive Viva course. So we allocate a little bit more time, and the faculty have picked cases that probably warrant a little bit more discussion, and we need to make sure that you get it right for your exams. So the way the course will run is that we've allocated an hour to each section, and there's 6 questions, 6 candidates. We'll give you a bit of time to walk through the answer, and then we'll give you the information that we think should be in a model type of answer. There should be time for questions, and the focus will be on the participants, but if the observers have some questions, then we can always discuss them as well. And we've allocated a lunch break in the middle, and we'll do a summary at the end of the day. So we've already named you all. So P1 to 6 will be the participants, and we can see that usually. And we'll just go through and ask you we'll have a little chat at the end. I went to an updates course last Saturday, and I got some information on the part 2 exam about what we can expect in the future, so I'll have a little chat about that at the end of the day. But as it's now 9:04, I think we should probably start soon. When Firas comes back, we might run through his slides at some stage, but I can't move them on. It looks like he's just going to outline the course and so we've also got the intensive Viva course coming up next weekend, I think, in combination with OR UK. We've also got a basic science course, which is running, I think, the week after. So they're all available on our website, which is orthopaedicacademy.co.uk, and you can book onto those if there's spaces available. So I think we can. Firas is back. Firas, are you with us?
Can you hear me?
Yes, we can. We can. We can't see you, but we can hear you.
Yeah, I'm very sorry about that.
That's okay.
I don't know what happened, but can you hear me now? Okay, yeah.
Yeah, we can. So I just outlined the course, and
I was hearing you completely.
Yeah.
Thank you for that. So obviously, if you see my screen, this is our faculty have been handpicked for their teaching skills, particularly in the field of FRCS exam. And as Nikki explained, it will be a case discussion course where we take you through the cases. They are high yield exam specific questions. So you most likely will encounter few of these questions in your exam. Okay. These all previously asked exam questions. So what I encourage you guys is, this is going to be a long day for you. Yeah. And that's exactly how the exam will go. The exam is a long day. Yeah. So look at this as a marathon. It's not a sprint, and stay focused throughout the day. So when you are asked the questions, obviously you are in the spotlight, but when your fellow candidates being asked questions, also stay focused and imagine this question being asked to you. And when the answer is given, see if it goes in line with the answer you were going to give if you were the candidate. We're not here to teach you orthopedics at all. Yeah, we are here just to encourage you and mentor you to score your highest potential score in the exam. Okay, well, I ask you to please, guys, obviously, as you could see to me, there can be technical problems. Don't worry about it. If you miss out anything, we will go through it again for you. But please, if you're not answering, stay muted, and just to give your fellow candidates time and the space they need to answer. Okay. And obviously follow us, and we're doing some more courses, case-based discussions and basic sciences courses. So you'll be very welcome to discuss those with you later on if you're interested. And without further ado, we will start the course now. So we'll go through the all stations of the exam as it is, with a new format. And we will start with basic sciences, as you are all guys fresh in the morning. So we have allocated you candidate participant from 1 to 6, and we will go into in that order. Yeah. Observers, obviously there are a number of observers here. Some of them could not get a chance space because we are limited, obviously, because of structure of the course to how many participants we have. So yeah, there will be a number of observers as well with us. So without further ado, I will hand over to Mo now to start the basic sciences session.
Morning. Morning. Right, okay, so just start my 10 minutes each. Okay, right. So watch this video for me and tell me what you see.
Okay, say video of a patient walking. I can see her using a stick on the left. I can see that her hip is sagging on the right. This would be in keeping with a Trendelenburg type gait. The shoulders do not seem to be drooping that much. So I would expect, yeah.
Okay, so mentioned Trendelenburg's fine, yeah. What do you think of which side she's holding the stick?
So she's actually holding, so I was looking at this, she's holding the stick on the left, which would indicate that the problem is on the right. This would indicate that she's attempting to bring the anti-clockwise movement about the hip to put the abductors at an advantage on the right side. So
okay.
that would be
do you
my
think, okay, but you mentioned she's got Trendelenburg's gait. Which abductors are therefore affected in this scenario?
So the abductors that would be affected will be the right abductors. As
are you sure?
In order for you to increase your anti-clockwise moment for a Trendelenburg gait, you must
is she holding the stick on the right side?
She's holding it on the left side.
Is she doing it correctly?
No, because if it was a true Trendelenburg, the opposite side, so the unaffected side, so if the right side was affected,
yeah,
the left hip would be drooping.
Yeah, so you expect her to hold it on the other side, isn't it? So you'd probably advise this lady to hold it on the other side because they're not doing much, you're right. Okay, we'll move on. So what are the definitions and prerequisites of gait? How would you define gait?
Okay, so gait is a complex coordinated motion which applies on a number of on prerequisites. It allows it's a study of how the human body propels itself in movement. The prerequisites are as per Sanders classification, I believe, which is looking at stability in stance, economy of movement, clearance in swings, stability, so stability in stance.
Okay.
Prepositioning.
I found this on the web.
Oh, sorry, my watch. Prepositioning of the foot, economy of gait, clearance in swing, and stability in stance.
Okay, fine. So, great. Now, you mentioned there the prerequisites. Okay. Now, what about the components of gait?
So the components of gait are either, so the components of gait include
gait cycle.
Yeah, so the stance phase and the swing phase. The stance phase makes about 60% of the entire gait, whereas swing phase makes about 40% of the gait cycle. In terms of the stance phase, sorry, the stance phase, it's to do with the heel strike. So it's into 3 rockers: heel strike, flat foot, and then toe off. And it's to do with contraction of the muscles associated with this. So in terms of the heel strike. It's eccentric contraction of the tibialis anterior, followed by the midfoot or flat foot would be eccentric contraction of the gastrosoleus complex, followed by concentric contraction of the gastrosoleus complex. This allows the patient or human body to move. In terms of swing, there is pre-swing, mid-swing, and terminal swing.
Okay. Okay. Now, what about the rockers of Gait? What do you understand by the rockers of Gait?
So the rockers of Gait enable initially for us to accept weight. So initially it's the weight acceptance. So when you strike your heel, it then goes on to the flat foot and then toe off, which locks the show part joint, tightens your windlass mechanism, allowing for a stable foot to be able to propel us forward. So there's a number of mechanisms that are associated with this. As I said, the locking off the show parts joint, where the lines are now not parallel, but they're crossed. The subtalar joint itself everts and locks itself as well with the screw home mechanism. Sorry, the Archimedes screw type mechanism of the foot.
Okay. Okay. So we kind of go off slightly. In terms of what's the ground reaction force doing in each of the rocker stages? So quickly,
Okay.
in the first stage, so what first rocker, what is it doing?
Yeah, so the ground reaction force would be behind the knee to allow the knee to be an extension and to allow.
And the second?
It would be in front of the knee.
Okay.
And then it would return back to. I think it would remain in front of the front of the knee. Yeah.
Okay. Right. Okay. We better just go through things because I think we've got about 3 minutes there. Okay. So how did that go?
I know I've not looked at it recently, so it was a bit muddled.
No problem. I apologize. I think Fras just told me the video was only half showing.
That's okay.
Was that the case? Oh, I do apologize. Yeah, so
the video showed okay, Mohammed. Just the slides are just the left hand side of the slide, just a little bit few letters are missing. I think
what, even this one?
I can see this.
Yeah, that's better. Yeah, thank you.
Okay, apologies. Yeah, so with this, you described it perfectly in terms of Trendelenburg's gait, but you got thrown off the fact that she was holding the stick on the wrong side. Okay, yeah. So you described Trendelenburg's perfectly, but you kind of you changed your answer because she was holding the stick on the left side, so you thought it must be the right side that's affected, but she's just not doing it correctly. So stick to your guns. If you feel this Trendelenburg, say this lady's actually holding the stick on the wrong side.
Right.
For the following reasons. Okay, so you were right. Don't let it sort of sway you, because that might be a trick. They want to see if you understand what's going on. So yeah, so gait is something to definitely brush up on. Okay, it can be a very common question. So you mentioned the prerequisites. Okay, remember as paces. So pre-positioning of the foot, adequate step length, clearance and swing, energy conservation, stability and stance. Okay, so just remember those sort of prerequisites. When I mentioned the gait cycle, just sort of break it down. Okay, so be quite sort of clear. Just say the gait cycle split into the stance phase and the swing phase. Stance comprises 60%, the swing phase 40% of the gait cycle. It stands for gait cycle goes from the heel strike of one foot to the heel strike of the same foot. Okay, that's one cycle. Then that way the examiner knows what you're talking about. And then the other thing is split the stance bit up into heel strike, load response, mid stance, terminal stance. So there's pre-swing. So there's five bits to it, and then 3 bits to the swing part. You can rattle that off. So that is the gait cycle. So you've described it. Just be careful about going into the muscles because that's massive. And you can talk about the muscles around the hip, around the knee and around the ankle. Okay, so that's just that's too big a topic. So I didn't quite ask you that. I asked you about the gait cycle. Describe the gait cycle. So, you know, be careful to answer the question that's given to you. If they want you to elaborate on a particular part of the gait cycle and what muscle function is happening around it, then they'll ask you that. We then go on to the rockers, and you understood the rockers. You know, you described them. You mentioned rockers earlier about the gait cycle. Be careful with rockers. Rockers are only involving the foot and ankle joint. Okay, they only describe what's going on at the foot and ankle joint, and nowhere else. So, you know, people just throw rockers in while describing gait, and you might get yourself, you know, in a bit of a mess. So, so the rockers, briefly. So yeah, heel strike. You can even mention the class lever, class 2 lever. So you're right about the ground reaction force behind the ankle joint and the knee joint, creating a flexion moment. Okay, so it flexes and then it goes anteriorly. Part of the second rocker creates an extension moment, and that's a passive motion. Then, isn't it? You've locked your knee. It's a passive motion, and then it goes on to the third rocker. So you're right about the contractions, eccentric contraction of tibant in first rocker, eccentric contraction of gastrocs in the second, and concentric contraction of gastroc in the third rocker as well. Okay, so you're right about those. And you know, if you're doing really well, they could go on and ask you about how, you know, ground reaction AFO works. You know, because that applies. What's going on in terms of ground reaction force, patients with CP and weak gastroc muscles, and how it, you know, counteracts flexion moment at the knee and the ankle joint in the stance phase. So, because, you know, CP patients collapse, don't they? You know, they can't extend their knee, gastroc's not functioning, they're flexed, and you know, it's quite exhausting. So this ground reaction AFO helps to prevent the knee from collapsing, keeps it a straighter moment in the mid stance phase. So just something, so that could have gone onto there if you're doing really well, kind of applying it to you know, to a real situation, because you can get that in the ped station as well with a CP patient, you know, things like that. Good. So yeah, just
sorry, this is a knee extension ankle plantar flexion moment, coupling.
Yeah. So you're that's it. You're helping by fixing the gastroc. You're helping to keep the knee extended. Otherwise, it will collapse down. So you've got the ankle. You've got the solid anterior tibial strap that's giving you that the force anteriorly to keep the. Because what happens is the tibia wants to progress, doesn't it, during the second rocker, and that's the tibial progression. So it will continue to progress because there's nothing counteracting it, because gastrocs is weak. So you're counteracting it by having the solid part anteriorly to prevent the tibial progression going further. You know, in these sort of CP patients or anyone with gastroc weakness.
Mohammed Mahmoud is the next candidate.
Okay, Mohammed. So one of the things about the exam, particularly in pediatrics, is not necessarily the most complex things, which we might touch on some of those soon, but it's how you're going to manage as a day one consultant, and how you know, what are you going to do? So classic thing would be an off-ended forearm fracture, you know, and there might not be a trick to it. They just want to know how you're going to handle it. And so this is one of those cases. So we're going to talk about this, Mohammed. So you've got a 14-year-old female who's come in when you're on call, first weekend on call as a consultant. I'm sorry, I don't have the lateral, but she's come in and the emergency department have called you and said, look, this girl's got a tibia fracture. We've put it in a back slab. What do you want to do with her? So,
okay.
Yeah.
Okay, so this is an AP radiograph of this girl left leg in a plaster, and it shows a spiral fracture at the junction of mid lower third left tibia. I cannot. It looks like the fibula is broken at a lower level as well. You said that you don't have a lateral view, so
sorry.
So I would like to I would like to take a history from this patient about the mechanism of injury. Was it a high injury, or is it a low energy injury? Any other associated other pain elsewhere in the body? I'll approach her according to the ATLS protocol, making sure that there is no other injuries. And then I would assess her neurovascular status and soft tissue envelope, excluding any open injury and excluding any signs of compartment syndrome.
Okay.
As well.
All right. So she's a basketball player. She's a very tall 14-year-old. She was playing basketball and she landed and twisted on her ankle. This is an isolated injury. It's closed. And she's otherwise fit and well, neurovascularly intact, no medications, no allergies. How would you like to treat her?
Okay, so she's 14 years old, so she's nearly an adult now. Cannot comment. I mean, giving that one view only, but for this, I would be more inclined for internal fixation of this fracture. So my options are if the proximal tibial physis is closed, so I may go for an intermiddle interlocking nail, or if not, I may consider I may consider flexible nails for fixation.
Okay, so you've mentioned the growth plates, and she's 14 and she's very tall. What's the problem with using flexible nails in this scenario?
So this fracture is rotationally and length unstable. So and also she's 14, so she's her weight is not appropriate for using the flexible nail.
Yeah,
for that. However,
I'd agree. Okay, so we're gonna do a tibial nail, standard tibial nail.
So I may consider suprapatellar nail or a standard tibial nail. Yeah.
Okay. So is there anything in particular that you would be thinking about doing a tibial nail in this girl?
Yeah, I mentioned about the gross plate.
What size nail are you going to use?
Yeah, the medullary size will be a bit challenging. It will be smaller than the usual.
Okay.
So I may consider using like a smaller diameter nail for that.
Okay. Are you aware of what sizes we can use?
I think it's maybe size 9.
Okay. All right. Let's stop there then, because we're coming to the thing. Okay. So how do you think you did?
I think it's tricky, just giving one view and a plaster as well. So I don't know if it's a recent or old injury from the first place. And then it's difficult to treat with the 14 years old. You can consider non-operative treatment if the alignment is fine. I was about to say that as well. But I cannot judge that with just one view.
I think you can say that in the exam, but as I said at the beginning, this is another one from my fracture clinic. I had, good fracture clinic the other day. And she's 14, she's very tall. And she wants to get back to sport, obviously. And I agree with you. And so this is what we did. We did a tibial nail. Standard tibial nail. Okay. The point about the question about the implants is because if you take this patient to theatre, so the smallest one that we have on the shelf is a 9mm diameter. So if you want to use a tibial nail, what are you going to do if the patient's anesthetized on the table and you can't get a 9mm down? They do an 8mm, but you need to order it in. Okay. And the point about the 8 and 9 millimeter tibial nails is that your locking screws are smaller. All right. So in the traditional nails, they're 5 millimeter locking screws, but in the 8 and 9 millimeters, they are 4 millimeters. So you need to remember that and make your scrub nurse aware of it. Okay. So these are just little technical points that can come up as you being a day one consultant on call. You're on call with the most junior registrar. Your anaesthetist is drinking coffee, and the staff are all obstetric staff in the theatre, and you've got a 14-year-old professional basketball player. All right. So the point of the exam is to make sure that you are safe as a day one consultant. And these are all the little things that they can throw at you because it's real life. Yeah.
Yeah.
But, you know, I think you did well. You could manage it non-operatively. I agree that flexible nails are probably not appropriate. This girl was 82 kilograms because she was over 6 foot tall. And you're right, trying to control the rotation would be difficult. And she's 14, her growth plates are almost completely fused, and a tibial nail is a good option for her. And as you can see, we got a good reduction.
Yeah, it's very nice.
Yeah, and so she's happy with it. So we'll just, you know, consider prophylactic treatment and get her moving as soon as we can when the wounds have settled down. But yeah, I think that was a good answer. So just be aware of the way that they can take you. You know, and yeah, that's it. So those two first cases were all about what you're going to do day one consultant. All right. So
yeah,
be prepared for something that might be easy, but you need to know when you're in charge how you're going to handle it. That's the main thing. The exam.
Yeah.
All right. So,
Nikki, hi, Nikki, is Vipul.
Hi.
Nikki, just wondering if you find that the medullary canal is not wide enough to accommodate 8 or 9, what options we have for operating with the length unstable fracture?
So you'd need to consider something like a plate if you were going to go down that route.
Yeah. And can this patient be initial x-rays? Could suppose the lateral, there is no gross angulation expected in the lateral, could have been treated non-operatively, because I understand the rotational threshold is quite acceptable.
Yeah, provided you keep close follow-up.
Yeah.
And you mobilize it. You might need to wedge the cast. You might need to manipulate it a little bit. Yeah, non-operative is always an option. Yeah. What I've found is, particularly with kind of athletics in children and adults, there seems to be this push from the coaches to nail them all so they can get back to sport any sooner. But you shouldn't be put under pressure by that. You could certainly manage this non-operatively, but I would say keep close follow-up, regular x-rays until you've got callus. Okay. All right, let's move on.
So, Ijaz, you are sitting in clinic and a rheumatologist sends you this 67-year-old lady, okay, presented with right knee pain. This is her X-ray.
These are 2 AP radiographs of both knees. I can see that there is a valgus alignment of both knees with lateral joint space narrowing and signs of degenerative changes here. I'd also like to get lateral views of both films. Did you say she was rheumatoid?
No, she was sent to you by rheumatologist.
Oh, I see. So the diagnosis here is valgus pattern osteoarthritis, which is bilateral but symptomatic in the right knee. Prepared to start by, in my assessment, doing a full history, asking about when the pain comes on, whether the pain is related to activities, whether it stops her from doing her daily activities, if there's any other joints involved, and particular attention looking at her past medical history and medications as well. I'd like to know if this is a sort of systemic problem also. without changing my sort of management down the line. And then I'd like to get sort of further weight bearing. I'm guessing these are weight bearing films.
After history, what you'll do next?
So then I'd like to do examination. I'd like to check the affected limb, check limb length, check for any fixed flexion deformities, check the range of movement of that knee.
You're not going to make her walk?
Start off with gait, sorry, yes. Get her to walk and assess her gait, and then again down to the couch and do sort of focus examination of the knee. I'd like to see if this is correctable or not, and I'd like to see if there's any fixed flexion deformity.
Good. Okay, you checked that there's a deformity of around 20 degrees, valgus of around 20 degrees, which cannot be passively corrected. Okay, and range of motion is 20 to 100 degrees. Okay, what else you're going to check?
Clinically, you want to check that it's not coming from, there's any spinal or pelvic conditions. So I would ideally, next, I'd like to get long leg views. And then. Okay,
that's fine. So what are the causes of valgus arthritis, lateral compartment arthritis?
So you can get idiopathic sort of osteoarthritis, you can get inflammatory arthritis, post-traumatic arthritis, or secondary to previous infection.
All right, okay. So you are saying that valgus arthritis can be idiopathic, rheumatoid, post-traumatic, or post-infectious?
Yeah.
Any other cause? Okay, that's fine. So valgus arthritis is arthritis affecting lateral component, isn't it? Compartment. So from the mechanics point of view, what happens actually on weight bearing?
So on weight bearing, your central axis is medialized.
What is central axis?
So it's from your center of your hip going through the center of the knee to the center of the ankle.
Okay, and what happens?
So it's lateralized, yeah. Sorry.
What happens to it?
So it lateralizes, so the pressure goes through through your.
That's fine. And so this is a valgus arthritis. How will you do your pre-operative assessment? You're taken history, examination, you're diagnosed. So if you're thinking now about knee replacement, because she's functional and she's probably failed conservative treatment started by rheumatologists before. So what is your pre-operative assessment?
I'm already thinking that this is going into the complex primary category, and I'm thinking she may need constraint devices, and I'd also like to check the integrity of it.
What is a constraint in knee replacement?
So you start from the sort of least constraint, which is your cruciate retaining, then it moves up to your posterior stabilized, total stabilized, and then further hinged prosthesis. So with valgus,
what is modularity?
So the ability to change components, either in the tibial or femoral components, to sort of change alignment, joint line.
All right, okay, that's fine. So you want to do knee replacement, isn't it? What are the principles in general of a knee replacement?
Principles are to achieve a pain-free functional joint. So surgical principles are to achieve a balanced knee, both soft tissue and bony, with bony cuts, and restore the correct alignment.
Okay, so your aim of total knee replacement is to get painless mobile joint, isn't it?
Yeah.
So what are the principles of your operation?
So you're
going to keep the ligaments balanced. You're going to preserve the second thing you said is preserve the.
So am I getting cut off with my Wi-Fi? Was it clear?
No, it's fine.
Okay, fine.
All right.
Yeah,
so,
it's fine. We can hear you fine.
It's fine. Don't worry. It's just an exam scenario. So
yeah, okay, fine.
get that hit. So as the causes of valgus arthritis can be rheumatoid, commonly rheumatoid arthritis. It can be trauma when you have fracture lateral condyle and then it malunites, or it can be metabolic like rickets, which is called genu valgum, and then develops arthritis. Or it can be post-infectious. You said in Asian countries, you get tuberculosis and then it heals and lives with arthritis. Okay, so these are things. So what happens to mechanical axis? Okay, mechanical axis falls lateral to the center of knee. Okay, so the full foot, or in other words, knee goes medial to the mechanical axis, isn't it? So how does normally mechanical axis, what angle does it make with the anatomical femoral axis?
So you normally have about sort of 7 degrees of valgus.
Okay, 5 to 7 degrees of valgus, isn't it?
Yeah.
If the person is tall, is it likely to be 7 or 5?
So more, as in 7.
No, if the person is tall,
okay, it'll be less than.
More likely to be 7 less, or 7 and more, or 5 and less?
So it'll be less than.
Okay, that's fine. So you're going to do pre-operative assessment. Basically, you're going to take history examination. All right. In history, you're going to ask him, how did it start and how is it bothering him, or sorry, bothering her? Okay, and what has been done for that? All right. And in examination, and you are going to ask risk factors. And in examination, you're going to make a walk and see for valgus thirst.
Okay.
And you're going to make a sit and kick and see for patella pal trekking, because common in this case, patella mal trekking, isn't it? And you're going to make a lie down, see this, where is the pain, all right? And assess the range of motion. Number 1, see if the deformity can be corrected. Check her ligaments and assess common peroneal nerve. Why? Why should you assess common peroneal nerve?
So it can come under stretch or with the valgus deformity.
Not really. Okay. So then most people would do a limb length alignment, all right, and get a good idea. Take a weight bearing AP and lateral. If it's rheumatoid arthritis, then you will tell rheumatologist that you're planning a knee replacement and you need some optimization. All right. And then you'll test her for other things, pre-op assessment, everything. And one of the important things is about common peroneal nerve again, because if you're going to correct it during the knee replacement, then you might cause it to be paralyzed because of stretching, hematoma, or a retraction or laceration. Okay, this is very important point. So when you're actually doing knee replacement, what are the steps, what are special precautions you're going to take?
So careful sort of lateral release.
You need lateral release, isn't it?
Sorry?
You need lateral release.
Actually, so careful sort of lateral release, meticulous hemostasis.
So start with the incision. You're going to put tourniquet, isn't it?
Yeah.
You take medial patella approach, isn't it?
Yeah, medial parapatellar approach, supine, with the knee flexed, avert the patella.
Then you'll do limited medial release. You're not going to do too much like varus knee. And you might have to do a lot of lateral release, which starts from taking osteophyte down, capsular release, IT band release, okay, release of proprietor's tendon, etc. Isn't it? Then when you are, you can take distal femoral cut, but when you are trialing, then what is required? Trialing, because there might be hypoplasia of lateral condyle. You have to follow the white side line for getting the rotation proper, isn't it? Then possibly you have to use a if there's a flexion deformity, you have to possibly use the cruciate substituting thing. And last but not least is you might have to resurface the patella because there's a more chance of maltracking and pain. These are the things. So the patient develops foot drop, then it can be either hematoma or laceration, which is, I don't know how to release, but depends on your surgical acumen and your thing, or it can be stretching. So first two things are treated operatively. The second, stretching, is treated with conservatively. So in bargain, in summary, sorry for that. In summary, you have the X-ray of both knees shows valgus arthritis of both knees. Okay, I will start with the history, asking how this problem started, how it's bothering you, her, and what has been done. I'll ask for the risk factors. I'll make patient walk, see for the valgus thrust, see where is the localized pain, see range of motion, correctability, ligaments, and common perineum, and then hip and spine. I'll do leg length weight bearing views, probably the long leg views. Okay, and if it's a rheumatoid arthritis, then I will have a review by rheumatologist because she needs optimization of rheumatoid arthritis. I'll start with conservative treatment. If it's not working, then operative operation. It requires, other than what you've done in history, same incision but limited medial release, more lateral release. I told you structures. You might have to do posterior release or use a cruciate substituting knee replacement. During trialing, you have to prevent axonal rotation and probably resurface patella. All right. So these are the thing which direction should go. All right, young man.
Yeah, thank you.
This is the fourth case now. So 27-year-old fell from mountain bike, sustaining this injury, isolated, closed. So tell me what you see on x-rays and define, first of all, tell me what exactly the diagnosis is, and then tell me how you're going to manage.
Okay, so I can see here AP lateral and, sorry, just a minute, I'm just moving. Yeah, so PA and lateral views of the wrist, right wrist of this skeletally mature individual. The most striking feature is the fracture dislocation of the wrist with the completely disrupted gilula's line, and there is an abnormal position of in the AP view. I can see the scaphoid is in flex position. There is an abnormal overlap of the lunate over the capitate, and in the lateral view I can see the lunate is not placed in the lunate fossa. So this is a lunate dislocation with Mayfield type 4.
Okay, and describe the images that you see below, the post-reduction ones.
Sorry, the post-reduction.
Or at least the labeled post-reduction ones.
Okay. So, I was describing this only. Sorry about that.
All right. Okay. No worries.
Okay. So though they are post-reduction X-rays, radiographs, so I can still see on the AP radiograph the abnormality is there, and there is complete disruption of the proximal row of the carpal relationship, and flexed attitude of the signatoring sign of the scaphoid, the abnormal overlap of the capitate with the lunate, and lunate is absent in the lunate fossa. And in the lateral view, I can see there's a spell teacup sign. Lunate is not well oriented in the lunate fossa, and there is a complete dorsal dislocation of the distal rest of the carpal bones from the lunate. So this is a lunate dislocation.
Okay, how are you going to manage?
Okay, so my initial assessment in the ED would be to take a focus history as to the exact mechanism of injury, the time since injury, the fasting status of the patient, any medical comorbidities. Then I will assess the patient, ensuring that this is a closed injury and ruling out any compartment syndrome. I'll assess the neurovascular status, especially the median nerve, because I'm expecting possible compression of the median nerve because of the nature of the injury. I will assess and document that. I will also look for any associated injuries in the hand as well as in the elbow. And apart from that,
you've done all that. How would you like to proceed from then on?
So considering this, there hasn't been no reduction attempt, I will do one single reduction attempt in the ED under conscious sedation.
So that's what you see the pictures there.
Okay.
So the
So
ED
if this is
doctors, they have attempted a reduction. As you can see, it is labeled as post-reduction.
So I would not give any further attempt of reduction. On the basis of the clinical assessment, if there are no median nerve symptoms, this would need emergency reduction in the theater. And if there are median nerve symptoms, I would do an extended carpal tunnel release as well at the same time. So I will inform the theaters for a possible emergency procedure. I will get in touch with the anesthetist. At the same time, I will talk to my hand colleague about my plan. And if they are happy for me to go ahead with the closed stroke open reduction and extended carpal tunnel decompression, I will go ahead with that. If I'm
assuming you are a lower limb surgeon, what would be and you're on-call consultant, so what would you do?
So basically,
go ahead and fix everything?
No. So this injury has 4 components. One is the decompression of the median nerve. Second is the reduction of the dislocation. Third is the fixation of the carpal bones, and the fourth is the ligament reconstruction. I would be okay to do the initial reduction and extended carpal tunnel decompression. And with the after informing my hand colleague, I will leave the fixation and the ligament reconstruction for them to take over once the patient is stable.
Do you want to get any further imaging?
Considering the nature of the injury, it seems to be quite a high energy trauma, though it's an isolated injury. I would like to get a CT scan because there are abnormal overlapping of the carpal bones. So there could be a possible scaphoid or other carpal bone fracture, which I would try to delineate with the CT scan.
Yes. Okay. So you have done the CT scan, and as you correctly identified or showed some concern, there is a scaphoid fracture, there is a triquetrum fracture, there is also a small ulnar styloid fracture. So now you have decided to go to theater. Tell me, are you aware of any specific maneuvers that you're going to try to reduce this dislocation?
Yep. So I will consent the patient for a closed stroke open reduction and nerve decompression, and appropriately marked and consented patient supine with the arm on the arm board. I will give a adequate longitudinal traction and sustained traction for around 10 to 15 minutes.
How?
By Chinese finger trap method. Following this, I will do the extreme extension, hyperextension of the wrist, and then anterior-posteriorly directed pressure on the lunate, pushing it into its position, and then hyperflexing or volar flexing, palmar flexing the wrist. So if I'm able to achieve the reduction, I will put the limb in the back slab and do the X-rays again. If not, I will go for an open reduction through the volar approach.
Okay. All right. So tell me about the, you mentioned about the disruption of the gilulars lines. What are the likely structures that are damaged apart from the dislocation and fractures?
Okay, so
So I'm asking about the ligaments essentially.
okay, so the ligament that are disrupted are the radioscaphoid ligament, then the capitolunate ligament, lunatotracheal ligament, and the.
Okay. Okay, I'm going to stop you. Can you tell me the sequence that normally results in this kind of lunate dislocations? You know, the pathoanatomy, how this injury occurs, or what is the sequence of failure of the ligamentous structures?
Yeah. So according to the Mayfield's classification, in type 1, it is a scapholunate or a radioscaphocapitate ligament injury. In the type 2, there is a capitolunate ligament injury, additional capitolunate ligament injury. In type 3, there is a lunotracheal ligament disruption. And in type 4, it's I'm just getting confused. I think it's the.
Carry on. You're saying it rightly. Yes.
The last one is, I think, radiolunate disruption, ligament disruption.
The fourth one is when the lunate is.
Yeah, the lunate dislocation. Yeah, I think I'm not sure about that. Most probably, it's a radiolunate ligament disruption.
Okay. All right. Okay. So you've attempted the close reduction. You were successful in that, and you have done median nerve decompression. Now what?
Okay, so I will inform about this to my hand colleagues, and though I'm aware of the principle that it needs a ligament reconstruction, the dorsal scapholunate ligament reconstruction is approached from the dorsal aspect, and through the dorsal approach, and the lunotracheal ligament disruption is repair is approached from the volar incision.
Okay, so suppose you are the hand surgeon. Which approach you're going to take and why?
So I'm going
you
to
got a
take
scaphoid fracture there, which is displaced.
Yeah. So because I will because the ligament reconstruction as well as the scaphoid fracture fixation needs to be done. I will first note the level of the scaphoid fracture, if it is a proximal pole or a waist fracture. If it is a
fracture.
Sorry?
It is a waist of the scaphoid fracture.
Okay. So if it is a waist of the scaphoid fracture, I will do a percutaneous fixation of the scaphoid from the volar approach. And for the ligament reconstruction, I will take the dorsal Valgus flap for the ligament reconstruction.
Okay. All right. Okay, we're going to stop here. Let me just. All right, so this is being done. Can you see that?
Yeah, I can see that.
Yeah. Now, one thing is very important, that these injuries are, again, life-changing injuries. Depending on the patient's profession and the overall activity level, we need to inform the patient that this is a very nasty injury and it will never be going to be exactly normal as the other side. And most likely this patient is heading, do you know what next step will be in future?
Because I can see the position of the scaphoid, though it is out to length, but there is a significant appreciable gap between it, between the fracture fragments. So possibly it would result in a scaphoid non-union and subsequently scaphoid non-union advanced collapse.
Okay, so that's one thing. Yes, I agree with that. Anything else? So taking as a holistic approach, what do you think this patient is heading towards?
So later on, it's heading towards the different spectrum of the scaphoid non-union advanced collapse, and with the associated ligament injuries in the rest of the carpal bones, he would be heading towards a pan-carpal arthritis very soon.
Okay, so what would be the options then?
So the options, if the degenerative process is rapidly progressing and it ends up into a wrist arthritis, the options realistically are to go for wrist fusion or
anything else?
Wrist replacements, though they don't have very good results, but that could be an option.
Okay. Other options are also proximal row carpectomy. Okay, and wrist fusion is the ultimate one, which is where this patient is heading towards. So well done. Okay, so you follow that sequence, and the important aspect is that you realize that this is an emergency that needs to be taken to theater regardless of the time, and it needs to be reduced. And that helps in terms of minimizing the compartment syndrome and also the median nerve symptoms. Fixation wise, there are different ways, as you have mentioned. However, different hand surgeons have their different preference. But the ultimate point is that regardless of what is done, this type of injury is not very promising in terms of the outcome, and ultimately wrist fusion would be required. You follow the correct Mayfield classification sequence and describing the back anatomy. So well done. Okay.
I just wanted to know, I mean, when you were asking the approach, so could you tell me more about it? How can we approach?
Yeah, the only purpose that I asked you the approach, because you will be asking the exam, is not to, there is no right or wrong answer in that. Yeah. As long as you can say that I do this approach, and one of the reasons you can simply say that I'm familiar with this approach, and hence I would, and that is a justifiable answer. But you have other options, other answers to say that I do volar approach because of, the scaphoid fracture is, the pattern is such that I can fix it there, and from there I can continue extending my incision, and then I can do the median nerve decompression. So there are pros and cons. There are different ways, and hand surgeons, they haven't got any a unified view on this, how to fix them. The reason I ask you is to check that if you get confused, or you say, as long as you say some approach and you defend that with a reasonable answer, that is what is looked at.
Can I ask 2 questions, please?
Yes, go on.
So looking at the red dot X-ray before the plaster, is it a radiocarpal dislocation?
It is.
With a linear dislocation as well?
That's exactly why I put this X-ray on. Okay. So initially, from that AP view, it does look like that the wrist joint is dislocated. So radiocarpal dislocation is there. Mm-hmm. However, as they try to pull and improve the position, the bottom picture shows that it is the lunate dislocation.
All right, thank you. So that second question is, assuming that you are not the hand surgeon and you are in the middle of the night and you've tried the closed reduction and it's failed, so would it be enough to just decompress the median nerve through the extended carpal tunnel approach and just take the heat of the situation and leave it dislocated for the hand surgeon to do his approach, or should you go for the posterior approach or the dorsal approach yourself?
So again, the answer lies in multiple factors. Number one, timing. So for example, it's 6 o'clock in the morning, then you can simply do the decompression and leave it for the hand surgeon to come and take over at 8 o'clock. Second factor is this injury closed or open? Because that would lead your, if it isn't open, you need to do the open approach or extend from the open wound and try to reduce it. The third thing that needs to be taken into account is that if you simply do the median nerve decompression and leave it dislocated, this is not ideal. You should be able to attempt and open reduction. And this is the discussion that you will have before going to theater with the hand surgeon, that what approach he prefers. So some surgeons prefer volar approach. So they will tell you, yes, if you're stuck and you need to do the open reduction, can you do it volarly? Because I have plans on that. So you can do so. But there is no definitive answer to your question that I can say, yes, you can leave it dislocated, or no, you cannot, because that depends on multiple factors.
And just one final question, just kind of leading on from that. I've done X-fixes for quite bad carpal fracture dislocations. Is that an option here? You could say, I will just span this out.
Yes,
and span this.
that is always an option. You can span it, which is absolutely fine. And you would help the soft tissue to recover, or at least prevent it from getting worse in terms of the compartment syndrome or swelling.
Thank you.
Brilliant, guys. Any more questions? Fine, good. We can move on now. So next candidate, number 5.
I'll go rapidly through this. Okay, right, let's start the stopwatch. Okay, so you've got a 27-year-old female who's complaining of her ankle giving way. Ask me only a few questions, or what focus history do you need?
So I would like to ask this lady, is there any associated pain?
So no, only when she it gives way. So only when she gives way, she gets pain.
Okay. And is there any evidence? Sorry, and the chronicity. How long has it been?
Yeah. Okay. So it's been going on for a few years now. She keeps on giving way. She gets no pain. Otherwise, gets pain afterwards. But it's unstable yet.
Okay. And any history of locking episodes, or
no locking episodes.
No locking episodes.
No.
And I would also like to know, was there any history of trauma following which this has started?
Well, yeah, she's twisted her ankle a few times, so that's considered trauma. Yeah.
Okay. And I would also like to know, is there any problem on the other side, or is it unilateral?
No, it's just this side that she keeps
on. This side, okay.
Just keeps on twisting it.
Okay. So then I would like to examine this lady, and
So take me through your examination very specifically.
Okay. So specifically, I will be looking for any evidence of ligament laxity. I will see if there.
How would you do that?
I will do the Beighton score.
Good. Okay, so you do the Beighton score. Fantastic.
Score.
She's not hyperlax. She's normal.
Okay.
So you've done that. You've cleared that. That's very good. You do a general foot examination. What specific things do you need to do?
I'm looking for any obvious cavus deformity of the foot.
Excellent. So she has no cavus foot deformity. Why do you want to look for that briefly?
Okay, so the cavus foot deformity, they have very common association with the lateral ligament complex insufficiency.
Okay, fine. So she doesn't have that, so that's fine. So you ruled that out. She doesn't have a cavus foot.
Okay, and then I will specifically I will be looking for any tenderness around the area.
So she's got some mild tenderness. Anywhere in particular?
Over the anterolateral aspect of the midfoot or the ankle region.
Okay, so she's got a bit of tenderness there. Any specific tests you know about that you want to?
So I will be doing the anterior drawer test for the ankle, stabilizing the distal tibia, and doing the test in the plantar flex foot in plantar flex position, testing for the anterior tibiofibular anterior inferior tibiofibular ligament.
So just watch this video. Can you see it?
Yes, I can see that.
Excellent. Right. Describe what tests are they doing here?
So this is the anterior drawer test with the foot in plantar flexion. This is for the anterior talofibular ligament.
And why do you do it in plantar flexion?
It is done in plantar flexion to isolate the anterior talofibular ligament, so that the calcaneofibular ligament is not contributing to the stability of that.
And what else do you need apart from plantar flexion? What other position do you need to have it
In neutral position, I will be testing again the same anterior drawer, and that I will be checking for the calcaneofibular ligament.
Probably a little bit internal rotation. Okay, so you want to do internal rotation and plantar flexion to ATFL. So that's what you got there. What's the next thing you want to assess?
Okay, I will also see if the
what's happening here. What's this test called?
Yeah, so this is we are checking for the laxity, lateral opening of the ankle in plantar flex and in plantar flex and internal rotated position, and comparing it with the other side. If there is a difference of more than 5 degrees, then it is significant. Or if the unilaterally it is more than 10 degrees, that is significant.
What test is that, Pratik?
To be honest,
what's it called? It's called the Taylor tilt test.
Taylor tilt. Oh yes.
What are we testing with that? What are you looking at?
We are again testing for the lateral opening of the laxity of the lateral ligament complex.
What's gone? What's gone here in this patient?
And ATFL. ATFL is gone.
Are you sure?
Because it's in the plantar flex position.
It's not ATFL though. Look where he's pointing.
Okay. So probably it will be the calcaneofibular ligament.
Yes, this is for CFL. Okay, this is for CFL. It's a dorsiflex position. It's more plantar flex when it's ATFL. Okay, so it's opening up, and where his finger is indicating, because normally you feel CFL there, it's gone. Okay. It's not there, and you can see that the fibula is very prominent. So that has gone. Okay, so in a dorsiflex position, because that's where it normally resists, doesn't it? And you're right, about more than 15 degrees opening up, it's counted as positive. Very good. So those two are specific tests that you want to do, isn't it? So you've done that. What's your plan?
Okay, so I will also like to rule out if there is any evidence of during the examination, any evidence of synovitis or arthritis, or any tenderness anywhere else in that along the joint line, pointing towards
no other joint line tenderness. What things might you need to rule out?
So I would like to rule out any evidence of synovitis, arthritis, loose bodies, or any osteochondritis. I mean the function.
How are you going to do that? How are you going to rule out OCD?
Okay. So I will, during the clinical examination and followed by the relevant investigation, I would request for an X-ray, weight-bearing X-rays followed by an MRI.
So X-ray is normal, but yeah, MRI, good. So MRI, you want to rule out other concurrent pathology, isn't it? So OCD could be another pathology that's going on. Particularly, there'll be painful, ongoing pain. So she doesn't have that. Good. So you've organised MRI. So what's the sort of what would you do next? So she's got this, she's failed conservative management, she's tried braces, etc. She's come to you. What's your principles of managing this?
Okay. One thing in the history I'd missed, I would like to know the functional demands of the patient, and if there are
so it's affecting her day-to-day activities.
Day-to-day activities. Okay. And so my plan, the management plan, having tried and failed all the conservative treatment, especially in the form of physiotherapy. If they have done that and they are continuing to struggle.
That's failed.
Okay.
So failed. Move on.
Okay. So I will offer the reconstruction of the ligament of the lateral ligament.
Tell me a little bit about that. What do you know about what repairs are present? What would you do?
Okay. So I'm aware of the anatomical and the non-anatomical repair. And if there are high demand patients, or if there is a ligament laxity, or if there is cavus deformity of the foot, then the non-anatomical repair is preferable. Also, in cases where the lateral ligament complex attenuation is there, the non-anatomical reconstruction is. So
what anatomical repair are you aware of? What is it called?
Anatomical repair is the, sorry, you are asking about the?
Yeah, the anatomical repair that you mentioned.
Anatomical repair is the Brostrom's repair with the Gold's modification.
Good. What's the Gold modification?
So the Brostrom's repair is the repair using the native ATFL, and the Gold's modification is that it's reinforcement with the inferior extensor retinaculum.
Good. Okay, that's that, isn't it? And when would that not be suitable?
So as I said, in cases of high demand patients, or in cases of ligament laxity, or if they're associated cavus foot deformity, or the native ligament is very attenuated and weak, which is not or allow for the repair, then I'll consider the anatomical repair, but the non-anatomical repair. But the downside for this is it's not a very biomechanically stable repair, and it causes stiffness of the ankle.
So are you aware of them? What are they called? What's the anatomical with augmented repair called? What are they called?
So they are called the Evans repair, where the peroneus brevis is used. A whole of the peroneus brevis is used, or there is a Christman-Snook procedure where the part of the peroneus brevis is used to reconstruct the ATFL as well as the CFL.
What's the problem with these?
So you have to sacrifice you are compromising on the strength of the peroneus brevis,
and what's the problem with that?
Weakness in eversion, and also
it's also a very important lateral restrainer to the ankle. You're taking that away. Good, excellent. So the Evans and the Watson-Jones you spoke about, they're good, but they're not anatomical, are they? They're not reconstructing the ATFL or the CFL. The Christman-Snook is a bit better. What's the recommended, or what's the most up-to-date one then that's even better than these?
Most up-to-date one is the is the anatomical repair using a hamstring tendon graft. So that avoids the sacrificing of the peroneus brevis, but at the same time it uses it gives results closer to the anatomical repair.
Good. Okay. Right. Excellent. So that's your time up there. Project. So you did very well. Okay. So so how do you think that went?
I in the end I managed to get all the thing. I was forgetting a few things in the beginning.
No, it's good. It's good. So you know, I think it's important to go through things quickly and cover it. We took longer than usual because there's a bit of teaching in there. So if we cut that out, it'll be even shorter. So you need to get to this stage by 3 minutes in the exam. Okay, 3 minutes. You need to be talking about management. So it's very good. We covered a lot there. Okay, so I thought you did really well. You knew these tests. Just be a bit clear. You knew about the associated pathology. The areas of tenderness, your Beighton score you mentioned, which is very good. Pescavus, that's very good because they're prone to they're weight bearing laterally, aren't they? Areas of tenderness, you covered that. You knew what this test is. Just be aware of exactly describing it, because in the exam they might play a video like this and say, take me through this examination and what are they demonstrating. Okay, so that's that, and that's the other one that you need to be aware of, which you manage. And great, you spoke about anatomical repair. And if that doesn't work in certain situations, you need to augment the repair. Also consider arthroscopy to assess the joint surface while you're in there. That's the other thing to throw in there as well. Just shows that you're thinking about other pathologies. Anatomical repair we spoke about, and augmentation, you know, using...
Can you, I'm not aware of the Colville procedure. Can you just briefly...
yeah, it's very similar to the Crossman-Snook procedure, okay? But it's a bit more anatomical. Okay. It's a bit more anatomical of where, you know, like CFL is so biomechanically it's a bit more anatomical compared to the Christman-Snook. But this is not bad, you know. It's kind of a halfway house. These are old school now. They're no longer done. They're great. Okay. They provide stability, but because they're so stiff, they fail quickly.
So which tendon are we using in Colville procedure?
So you can use A tendons, okay? So you can use plantaris. You can also half of PB can also be used, okay? You're using half of PB potentially here, or any other grafts. That's fine.
Who have we got?
Yeah, it's me.
Mohammed next, yeah.
Mohammed, here you go. So you've got a 30-year-old lady. She fell on a dry ski slope about 2 weeks ago, and she thought she'd sprained her thumb, but it's not getting any better, and she's finding it difficult to grip things. So she's come to see you in the clinic. So tell me what you think.
Okay, so this is a clinical photograph demonstrating stress test of the thumb ulnar collateral ligament.
Mm-hmm.
So I would like to ask the patient about the hand dominance, the occupation, and the level of activity, any associated injuries rather than this injury, any treatment received so far, I would like to examine the patient, checking for any associated injuries, any neurovascular compromise, and the range of movement of the thumb as well. And then after that, I would request an X-ray of the thumb to rule out any bony avulsion of the ulnar collateral ligament. And on the examination, again, I would do the examination in extension and then 30 degrees of flexion to demonstrate or to differentiate between the ulnar collateral ligament proper or the accessory ulnar collateral ligament.
Okay, so which one is in full extension and which one is at 30 degrees?
So in 30 degrees is the ulnar collateral ligament proper, and then full extension is the accessory ulnar collateral ligament.
Okay. All right. So you find that there's opening on both positions. How are you going to manage it?
So I'd explain to the patient that this will need a surgical intervention to reconstruct the ligament or to repair the ligament, because usually this may be consistent with a Stenner lesion, which means that the adductor aponeurosis is interposed between the insertion site of the ulnar collateral ligament, and it prevents it from healing properly. So it will need surgical intervention to repair the ligament there.
Okay, so you tell me about your surgical approach.
So an appropriately consented and marked patient with a tourniquet on and the IV antibiotics, I do a lazy S incision over the dorsum of the metacarpophalangeal joint of the thumb, and I would explore the ulnar collateral ligament. I'd make sure that it's free from the adductor aponeurosis, and my repair will depend whether it is like a pure ligamentous injury or if it's a bony avulsion as well. But either of these will be to reattach the ligament to the proximal attachment using suture anchors, mini anchor sutures.
Okay. With your surgical approach, is there anything you need to be aware of that you may want to protect?
So yes, I would be worried about the here it will be the branches from the superficial radial nerve.
Yeah, and where are you going to find those?
So they are on, they exit at the distal end of the anatomical snuff box.
Yep.
So I'll try to avoid, or to protect this as well, and the extensor tendon as well, the EPL tendon.
Yeah. Okay. All right. So that's just more or less 5 minutes. So let's have a little go through the slides. So you did well. Okay. There's a couple of points that I'm going to come to in a second. So in flexion, your collateral ligament proper is tense, so that's what you're testing, and then in extension your accessory is tight and the other one's loose, so that's what you're testing. Which I think you got, and then you described the Stenner lesion to me, which is where the aponeurosis tendon is interposed, and these are just the ligaments and the pulleys. All right, so you can have a read through that. So that's why they don't heal, the Stenner lesions, because the adductor pollicis tendon is in between. So I think whenever you say describe your surgical approach, okay, you started off well with the appropriately consented, marked patient tourniquet antibiotics, but I always find it useful when you're asked about a surgical approach is to start with landmarks. All right, so for me, you said dorsal of the MCP joint. So the way that I would describe it would be a lazy S, I agree with you, over the MCP joint, maybe more towards the ulnar side. And then when you go through the skin, And the subcutaneous tissue, what you're going to look for is the branches of the superficial radial nerve, and make sure that you've retracted them out of the way before you consider on with your dissection. Does that make sense?
Yeah.
And that means, you know, that you've done it 100 times. We know that you know how to do it, and you can go on to get to the orthopedic part of the operation. I mean, you know, we're all about the bones, but you need to just, I always think if you start off with your landmark skin, what's in the next layer? It's like with the pediatric case with the lateral femoral cutaneous nerve, you know, think, how do I do it? What steps do I do in my head so that you don't miss something like retract the nerve, protect the structure. And then the examiner can just relax, and, you know, that'll be a box on the thing, protects neurovascular structures. That'll be a tick. That's marked.
Yeah.
All right. And it's something that you would automatically do, but you might forget under the stress of the exam. So that's why we practice it, so that it becomes automatic.
Yeah.
Okay. Does that make sense?
Yeah. I agree.
Beautiful.
Thank you.
Okay.